Welcome to ImmunoTea Time. I'm Ben,
I'm Paula.
and today we are drinking.
I brought a Spanish tea from south of Spain, from Granada. It's called Nazari, and it's a green tea from, it has like inspired in Arab times where Arab was ruling Spain, and it has orange blossom, spearmint, and cinnamon. So it's very refreshing, and I hope we can have a very nice conversation with it. So Ben, who are you introducing us today?
We're really excited today to welcome Dr. Tobias Rothe to the podcast. He's a postdoc at the Department of Rheumatology and Immunology at the Universitätsklinikum Erlangen, part of Friedrich Alexander University. Tobias works in Professor Gudishaber-Boyer's lab, where the focus is on understanding the immune mechanisms behind chronic inflammation and autoimmune diseases like lupus and diabetes. One of the reasons we invited him is his recent publication on the first ever treatment of systemic lupus erythematosus, SLE, using CAR T cell therapy, using CD19 CAR T cell therapy. It's a fascinating study that explores how engineered T cells might one day offer a cure for patients living with lupus. Today we'll dive into that research, how the therapy works, why CD19 is such a key target, and what this could mean for the future of autoimmune treatment. Tobias, thank you so much for joining us. Grab your tea and let's sip into science.
Thank you for inviting me and to serve this wonderful smelling tea.
I'm glad you like it. So yeah, just to start off with a very simple question, like could you tell us why did you start researching autoimmune diseases, or what was your path until here?
Oh, that was a long path. Initially, if I can go back.
Yeah, you can go very back.
So I started studying biology here in Erlangen. So it's basically like botanics and with animals and all that stuff. It was interesting, but I realized quite quickly that I'm more into molecular. What's the deal in the cells and so on, and it was really interesting and fascinating. But when I was doing my diploma in plant physiology, everyone asked me, "What will you do then later?" So yeah, and then I decided no, I'd rather switch to human research. And as soon as I switched to there, everyone, oh, what's new? What have you cured? So, but initially you're doing like basic research. So how things work, how they do. And then I joined Professor Gerd Krönke's group, who's now head of the rheumatology in the Charité in Berlin. And there we focused mainly on inflammation, how inflammation starts and how it resolves, and what happens if that fails, because then you get chronic inflammation and autoimmune diseases.
Mhm.
So, and we mainly focused on rheumatoid arthritis. My focus was in the first projects on multiple sclerosis. So neuroinflammation was really interesting because it involves a lot of cells, T cells, dendritic cells, macrophages, or in the central nervous system, it's more microglia cells. And it was really, really interesting. So because you get a big picture of how immune system works, the innate and the adaptive. And then as we started this therapy here in the clinic together with the Med5, I'm switched from more mouse-based research to human, and then also to SLE and a little bit of myositis and systemic sclerosis. But I'm not too deep into the two diseases. Yeah, and therefore also the focus changed from T cells and myeloid cells to B cells. And that was my way into this whole topic we will talk about today.
Very long path.
Yeah, but you will see
We will get to it, right?
Yeah. So for you, it will be the same. So in the beginning, you will learn about a lot of different topics or areas in the immune system, because there's a lot of them. And then somewhere you will see what excites you most, and also what groups are available with nice research. Yeah. And it also shows that you don't need to be fixed to one topic.
Yeah, that's a good example, because I think there is a lot of people very stressed with only fixing on one topic. So being able to change and having an example of that, I think it's very good.
Yeah.
But do you think starting somewhere else helped you to be a better scientist today?
Hard to say.
Yeah.
Because Erlangen has really good environment, especially for immunology. It's not like a real campus like somewhere, someplace else, but everything is quite close here, and you can work together with different groups from different departments, maybe dealing with the same question. But as we have the clinic here, they are more really focused on the bedside, and we can work with the more lab side of all the questions that come up in the clinics. So there's a good interaction here. This is really what I like. So I heard from other people in other universities, they're quite isolated sometimes also in their research, and it makes things easier and much more exciting if you can work together with other groups that have more key knowledge in some specific part. So we have strong B cell groups here that focus mainly on B cells. Our group here is a little bit more focused on neutrophils in context of autoimmune diseases. But if you can use the knowledge from other groups and combine that to understand the big picture, this is really nice, because you're not a specialist then in something, but you maybe can put together all the pieces to understand a complex disease like lupus. Yeah, because that involves also a lot of different cell types and a lot of organs and so on.
So to get a bit more into topic, so for people that is like maybe less familiar with what lupus is, just to say that lupus is like a chronic autoimmune disease where we can find autoantibodies that are antibodies that are created by our own immune system that will attack ourselves. Just if you could explain, it's like what is really happening in the immune system.
So I think with lupus, there's a lot of things going wrong. And I think it's not really known where it starts because there's so many things included. And initially, this disease was only defined by the rash you have in your face. Yeah, that's what gave the name, because you look like a wolf. So it was called lupus. And then later on, the people or clinicians realized that this is a lot more. So you have a lot of involvement of different organs. And therefore, to be diagnosed with lupus, you have to at least match like 4 out of 12 different symptoms. So you have a lupus induced arthritis, you have kidney problems, you have photosensitivity, and so on. There's a lot of things that together define lupus, and therefore it's sometimes hard to really know that you have lupus or only rheumatoid arthritis. So that already shows that every organ can be included, and but not necessarily. And one key thing is that you have a really strong reaction against DNA, self-DNA, and you have this creation of immune complexes that can then accumulate in the skin or in the kidney, inducing tissue damage and a lot of problems. Yeah, the tissue damage is one big problem, and also the immune complexes induce infiltration of other immune cells and ongoing inflammation. And there's kind of a circle that this inflammation doesn't come to an end. So usually when you have an inflammation, it somewhere stops. But here there's kind of a trigger that perpetuates everything, and it never stops. And one key thing is this immune complexes and autoantibodies that are produced against self. And this can be due to either problems in removing self-antigens correctly from the body, or also stopping immune cells that react too extensive to self-antigens like B cells, T cells, and so on. One driver is, for example, also the T cells that can destroy tissues. So, but you will always find in the blood is this autoantigens or autoantibodies against autoantigens. But the question is if this is just a consequence, or is that really driving? So this is not really known, because the question is what was the initial trigger to induce this disease? Yeah, but you have a lot of problems when you have this disease.
So, and for example, nowadays in the long term, so if someone is diagnosed today with lupus, what that person can expect of his life? Like it's like, can that person live normally or not? Or
so that I'm not a clinician, so therefore I'm not so close to the patients. What I hear from the clinic side is because a lot of young women are quite prone to be diagnosed with lupus, and it impacts their life a lot. Because if you have like or it's like that you have sometimes really like a push where you have strong problems or effects of the inflammation. Then what I heard, so they can hardly do anything. Yeah, they're tired. They yeah, you have fever. You're sick. You really don't feel well. You cannot really be part of the social life and so on. And people also get like strong medication to suppress immune system. That has also a lot of side effects that makes them hard to live a normal life. And you also have some kind, if it's really get worse, of reduced lifespan. It's not so dramatic like with other diseases, but this is also something that you have to face. On the other hand, there's a lot of medications that you can take to prevent from that, but it's really, so what I read, it's like for a lupus patient can be up to $100,000 a year just for treatments.
Yeah, that's a lot.
Yeah, and therefore finding a therapy that can lead to drug-free remission would really be a big goal. And this CAR T-cell approach is really something quite promising.
We will come to that
Yeah.
like a bit later, but yeah, it sounds like very promising because so right now we are having autoimmune diseases and the treatment it's like to remove the symptoms, right? But we still have behind the autoimmunity that is still the problem.
Usually it's to down-regulate the immune system, right? That's the treatment.
Yeah, so also I'm not expert with all the treatments, but most of the starting treatments you do is give some medication that somehow affects T cell quantity or quality. That will also be later something I will address because it's a problem probably for the CAR T cell therapy, but it doesn't always work so good. Then you give also B cell depleting antibodies to get rid of the outer antibodies. But it has also some, or it's not so effective in some patients, or it doesn't last for long. So the disease comes back after a while. So therefore, the idea was if it's possible to kind of reset the whole immune system, and then like you reset the computer when it has some problems, to start from the beginning. But that was not so easy because you can achieve that with like chemotherapy. For lupus patients, you cannot really do that because it's too hard for the whole body.
Yeah.
And if you're already kind of immune compromised, it can really have a lot of side effects that are not so good. And as compared to cancer, where you really have it's life threatening, it's always like how hard will you hit to cure if it is really necessary to be that strong in your treatment.
So with current treatments, can you use monoclonal antibodies? And you said before that they might not cure completely, right? Like it's not long lasting.
Yeah. So it's not really known why. So there's some hints why monoclonal antibodies don't work so well. So one antibody that is given is rituximab. It's again also against CD20 on B cells. The problem is you can really, with these monoclonal antibodies, you give them IV, and you can delete all the circulating B cells, or at least these cells that are CD20 positive. On the one hand, you don't know if you hit exactly the B cell that is producing the outer antibodies. So because CD20, for example, is not expressed on plasmablasts or plasma cells that are the cells that produce the antibodies, so you will not hit them. And also, these antibodies cannot really go into the tissue where usually the plasma cells are in their niche producing antibodies. And these antibodies also need some effector cells and the complement. And this is something that you have plenty in the blood, but in the tissue, probably not. And therefore, the effect of the monoclonal antibody is not that strong. And also they're used up somewhere. So that's also a limiting factor. And that's probably a reason why it doesn't work so well, not so deep.
Yep.
And depending also on the amount of B cells you have, different in patients. And therefore, CAR T-cell therapy has some advantages.
Yeah, exactly. So that's why we are coming to your very important study about CD19 CAR T-cell therapy in autoimmune diseases, case series with follow-up. So yeah, it sounds like very promising because as we said before, like the treatments right now are being to treat the symptoms, and this will be like a very important thing to cure actually the autoimmune disease. So just to know the people that is listening, like what are CAR T cells? Like CAR T cells are like special immune cells that like doctors and researchers reprogram usually to fight cancer, and they are made by taking patients' own T cells. And they then teach them to recognize and attack cancer cells. But here you did it with like to cure an autoimmune disease, and this is like the very important part, right?
Yeah. So the good thing is that everything has already developed, but no one, how to say, because there's a lot of risks. Yeah. So therefore, with cancer patients, for example, it's really like that's the last step you do maybe because it has a lot of risk. But against cancer, you're willing to take that risk. With autoimmune diseases, as you probably will not die from that. Taking that risk is no one.
Yeah, maybe not everybody is willing to pay
Yeah.
it.
So therefore, for the studies or for the first patients that were treated with that, they already underwent a lot of therapies that did not really work. So that was the starting line, and also no implementation. Or I think kidney shouldn't have been included because you can already have some damage that you cannot really reverse. But this CAR T cells, you were right, just a receptor. This is or expressed in your own T cells. So it's consists of an extracellular domain that recognizes your antigen. In this case, the CD19. It's only a single chain. Then you have a cytoplasmic part with a costimulatory part and also a CD3 part to transduce the signal. So it's like in this study a CAR T from the second generation. So there's already like 4 generations with more or less more costimulatory parts to better induce proliferation and effector function of these T cells. Yeah, and these T cells are you take them from your own body, from your own blood, so via apheresis. Then they get transfected with a vector that codes for this CAR receptor. And then when you have a stable transfection of these cells and they express the receptor, then you let them proliferate, that you get a good amount of cells, and then you infuse them back into the patient. They get a mild chemotherapy before to create a niche that these T cells can proliferate, and then they start proliferating. I think the highest amount of these cells you only have like 1 week after. Yeah, and then they circle through the body, can also enter the tissue. This is also something that is big advantage.
Yeah, that the monoclonal antibody that we talked before, it didn't do, right?
Yeah, or partly, not so easy. Yeah, they can also be. Can also enter, but not like a T cell can enter. And then they find their targets, destroy it, and within 1 or 2 weeks can hardly measure any B cells in the circulation anymore. Yeah, and these B cells in the circulation are gone for up to, let's say, 100 days, something like that. Then they're step by step come back in a naive stage, so that you can really say you have reset the B cell compartment.
Those naive cells that are new, they are not producing these autoantibodies anymore, right?
It seems so. Because what you can also measure in the blood is the levels of the antibodies, the autoantibodies, and they are down and they stay down. Interestingly, when you look for antibody titers for something that you have vaccinated early before, you can still see that these titers are there or a little bit reduced. That also tells you something about which cells survive on the one hand, and which cells are probably the ones that produce the antibodies, the autoantibodies. Because when you still have, let's say, for tetanus titer, and they are still keep their level, then probably the plasma cells are the ones that produce them, because plasma cells is one cell that you cannot target with CD19 because they downregulate CD19. But cells that do have CD19 and can also produce antibodies are the plasmablasts that you can also see to some part or that you see in the blood, and indicating that probably these cells have to do with the production of these autoantibodies that are still missing after the CAR treatment.
Yeah, so when we talked before about the rituximab, the monoclonal antibody, it was targeting CD20, right? And you used CD19.
Yeah.
So we have talked that CD19 will target B cells, it will target plasmablast, but it won't target plasma cells. So that's a plus for this treatment, right?
Yeah, definitely. But the question still is how long it lasts. Yeah. So right now, so with the first patient, it's nearly 5 years or something like that, and everything is still okay, perfect. So nothing is coming back. So the question is also how long it takes if there's still a wrong clone somewhere till something might come back, or if it really cleared out every potential autoreactive clone, and therefore will be seen in the future if this is the perfect target, or if you can maybe focus a little bit more only on plasmablasts with other markers, CD38, for example, that is also blast marker, or other markers that are right now also tested in CAR-T.
So with the CD19 cells being targeted being the plasmablasts, right, about the CAR T cells possibly, could you also interpret that as the CAR T cells being able to access those cells, and let's say they can't access the plasma cells which release tetanus antibodies and things like that? So you can say that the plasmablasts are depleted, which might drive the lupus. That's one way to interpret that. They still have long-lived antibody titers after the treatment, right? That the plasmablasts being destroyed. But it also could be that the CAR T cells can get to those cells more easily, right? And not necessarily get to the ones that produce the antibodies against things you vaccinate against.
Yeah, that because they are more in the circulation.
Yeah.
And in the circulation, it's easier to get the cells that you deplete. So in the tissue, it's a little bit more problematic. But this is something we right now to try to find out how deep the depletion is happening, because it's not so easy. Blood is easy to assess. Yeah, you draw some blood and measure what's floating around. But with tissue, it's not so easy. So you can do lymph node or whatever biopsies and check this is something that we want to do or starting to do, but it's on an ethical point of view not so easy to do. If people are or patients are willing, then it's easy, but it's a little bit more invasive than only drawing blood. So the hypothesis is that we deplete them also in the tissue, to what extent and what is really left and what not. This is not yet really known. But the results so far indicate that we hit the cells that seem to produce the autoantibodies because they are gone. Yeah.
But you don't want it to be too shallow because then the treatment doesn't work. But if it's too deep, then you get rid of immune memory.
Yeah, of course. Yeah. So what you definitely have to do, you have to give vaccinations afterwards. So I think if you also hit the plasma cells, and they would be gone, then you definitely have to do that, because for me it's always like you start like a newborn, or from the B cell point of view, and this is also something that would be good for the future if you only target really the specific cells, ideally, because you need also the whole B cell compartment to
fight every infection you have in general.
Because and after this CAR treatment, you have or no B cell levels, and this increases the risk of infections, of course. Yeah, and what I heard from patients that I talked to, when they get a flu or something like that, they have the feeling it takes a little bit longer, because you miss a lot of immune memory and so on. So this is really something that you have to be careful with, and therefore eliminating only the dangerous cells is ideal.
Mm-hmm.
And therefore now different targets are used that only target one part but leave the rest untouched so that they can do their job. That is the ideal.
Mhm.
But it's better to have like a slightly worse flu than having lupus, right?
Yeah, definitely.
So
Is there any other side effects? So
Yeah, of course. So this is the main part you have to check also
Yeah.
in these studies, because you can induce a lot of toxicity. The two main things that you're afraid of is the cytokine release syndrome.
Mhm.
Because if the CAR T cells start doing their job, they produce a lot of pro-inflammatory cytokines. And if you have too much and uncontrolled of these cytokines, then you induce a lot of pro-inflammatory cytokines into the circulation and can end with that. Yeah, and this is something you want to avoid.
Yeah.
What will happen to some extent is in the patients we had that they have like fever or mild fever or something like that. So this is the case, but this is okay.
Mhm.
And so far, there were no really dangerous side effects. And this is also something that the CAR T cell treatment from with autoimmune diseases differentiate from the when you have myeloma,
Mhm.
because the target cells are much reduced compared to in a tumor setting where you have
Mhm.
extremely more targets, more depletion, more cytokine release, and so on. So the target here is not so big numbers like in in cancer. And what you can also have is toxicity against the nervous system that you want to avoid. That can lead to depression, whatever, motor function or impairment, and so on.
Mhm.
This is also something that might be a risk, but so far we could not really detect a strong reaction. So therefore,
So it was good results.
yeah.
And how did you feel when you saw that it was actually working? So what you worked in the past, it was working right now in patients. So it was working in real life, and you were helping people.
So one thing, so we have a yearly meeting with patients, and this is where we really see the effect, because so far I'm only in the lab, so I have hardly contact with the patients. So the clinicians, they really see the difference. So I heard some stories where patients came here in really bad conditions, and they got back to life after the treatment, because we have not only lupus, we have also the systemic sclerosis and idiopathic dermatomyositis and so on. And there was one patient that I heard had to be carried in the clinic for the treatment. And 1 year later, this person was part of our retreat and was jumping around and full of life. And when you see something like that, then
Right.
you
That's
can
you a
really
bit, right?
Hmm?
It hit you a bit.
Yeah, everyone.
Yeah.
So they tell their stories, so how they what they went through and so on, and how it changed their life. So I think no one was without tears
Yeah,
when they
of course.
tell that story.
Yeah.
Yeah.
And so now coming back, like going into a bit of broader implications, do you think this therapy could be used for other autoimmune diseases in the future?
So
Maybe, I don't know, diabetes or something else.
Arthritis, something like
Yeah.
that.
as this is targeting B cells, so everything where there's a B cell involvement or autoantibodies, definitely, but it's already also tried. It's also only a matter of, let's say, bad the disease is and how willing you are to, because it's also with a mild chemotherapy, and don't know if you want to, or can people treat with the really hard treatment if they have only a mild RA or something like that. But therefore, there's also other concepts that come up right now with T-cell engagers that are a little bit more mild, but do exactly or try to do exactly the same. Maybe a little bit in between a monoclonal antibody and a CAR. Yeah, but definitely. So this treatment has a future, and is something that you actually should also consider in the initial phase, because as soon as you have tissue damage, this is something you cannot really reverse, but getting rid of all the autoreactive B cells in the first place, I think is, yeah.
Yeah, I also, now that you mentioned the T cell engagers, I also wanted to talk about this just for a bit because, like, they are smaller, right? And maybe even cheaper. So,
Yeah, there's also two things I would mention there. On the one hand, smaller, yeah, but they're easier to manufacture. Yeah,
okay.
because you can produce them in high amounts, and you can, depending on this T cell engager, either you get infusion via IV, but there's also some you can just inject subcutaneously, so you can really give the dosage to people and they can take it at home. But the depletion is not that long lasting.
Okay.
And still, they have to find the sweet spot in the concentration, because you start quite low and then increase the dosage. But there's a lot of still room for improvement to maybe increase the dosage to prolong the depletion. And then also the question is if you can deplete that deep, like with the cars, because the cars, it takes a while. So you really need like a special unit for creating them that they have in the Med5, but you can produce like or with this one lab, it's like 4 or 5 patients a month. Yeah, because it takes a while till you have the cells in a suitable amount. And then it's not always said that, because these patients are on a treatment before that affects the T cells. So that was one point. If you have immune suppressed T cells, they're not perfect in their function. Either they don't proliferate well, or the transfection is not working well. And if they're kind of compromised and you fuse them back, then maybe they are not that good like for another patient. And therefore the treatment also relies on that. So therefore the plan is to produce not autologous, but off-the-shelf cars.
Yep.
Yeah, that are don't induce an allergenic reaction. So, and then you can give them to the patients and maybe also give a second dosage if something comes back. This is not yet in place, but with the bites you have that already. You can produce them in high amounts, and then you can always give them with the same quality and so on.
Yeah, so another question. So with the like CD19 CAR T cell therapy, like what is the main problem to like this therapy can become like wider in clinically, so that everybody that has lupus can start using it? What do you think is the main problem? What are steps are coming now?
So it's not officially as so therefore you do the studies. Yeah, so you do the randomized studies that you get approved for this as a therapy, and as soon as you have that, then you can also use that officially and not off label. So therefore a lot of companies trying their products already or start trying that. And the downside so far is that it's quite expensive and time consuming. But as soon as you officially allowed to use it as a treatment for lupus, I think then it's the next step will be to more efficiently run that process, shorter time, or reduce costs. Yeah, because so far it's quite expensive.
Yeah.
But if you get a patient in, let's say, at least 5 years of drug-free remission, so it already, I think, equals the cost. So therefore, it's already worth.
Yep.
And minimize, of course, side effects. If people respond good to this, this is then I think then it's more easy to get it as a general treatment, because it still has the risk of side effects that can be really harmful.
Do you think in 2036 everybody will be like taking CAR T cells for lupus, like in 10 years?
Why not? Yeah. So if there's not something, a cheaper approach and easier to handle so like the bites that compete with that, then why not?
It must be so amazing to be a part of that.
Yeah, definitely. So I was not the one deciding to do that. So that was Georg Schett and Mackinson. They really did the point with the high risk, including, of course, the patient. But when you see how this goes over the whole world, and impacts a lot of lives. This is really, really great. And I realized that when I was on a vacation somewhere abroad, and then talked to some guy that works also in the clinic in another country, and then you are part of that team,
Wow.
and you really see how that impacts worldwide. So and we have also a colleague that came here from Japan just to know more or get consume knowledge about that. I want to bring that to Japan. So if you're only sitting here in your lab, then you also get a feeling for that, but you really feel that when you're outside and see people knowing that and then hoping for that this therapy is really.
It will change patient care in general. Like,
Yeah.
it will be very amazing for people to be able to come back to life.
Yeah.
So that's
And the thing is, it's not only lupus, it's also already a lot of other autoimmune diseases.
Mhm.
So MS also was treated somewhere else. But every disease is a little bit different, but it's really, really promising. And this is something really nice to be a part of, definitely.
Yeah. So now that we are reaching the bottom of our cups, we have like this last sip question.
Yeah.
So there are 3 questions that we are asking every guest that we have in the podcast. So it's just to get a bit of an overview about, like, they're a bit more personal.
Mhm.
So the first one would be like, if you could go back to yourself on your first day in the lab, what would you say to yourself?
Have fun with it, because when you go to we work in research, not everything will work as you planned it. So you will always have to do things twice or 4 times and so on, but you grow with that. You always have to evolve yourself. You come in contact with a lot of new techniques and devices and so on. So you will never stop feeling like a student. Trust yourself and because there will be setbacks, but like for the patients, but when you will manage it. Always be positive and have fun with it. This is the most important thing, I think.
That's a very nice advice.
Do you think you like change how you behave because of working in the lab? Like you, I don't know, maybe you measure your flour a different way when you're baking or something. Change the way you behave, or you do certain things a certain way because of your experience in the lab, outside of the lab.
So outside of the lab,
Yeah.
definitely, because here you always have to like defend your hypothesis and so on, and you have to be open to another point of view, because sticking to what you think is right, it doesn't really help all the time. And outside, if you not, there's a lot of topics that would touch it, like Corona or whatever. But outside, I'm also open for other views and try to understand the way other people think and be open to maybe find the in between. Yeah, also change the view. Yeah, and this is also something that I think is always helpful, and not a black and white, a right and wrong decision. There's also something in between.
Yeah. Tobias now have a very organized kitchen. Yeah. The second question would be like, what's one mystery, scientific or personal, that you hope to see solved in your lifetime?
One?
One. Just one.
Ooh, this is hard, because so this is already a good thing here with the autoimmune diseases. So I think everyone that got in contact with cancer somehow, is hoping that you can also have something comparable in that area, because it's much more dangerous and much more deadly than an autoimmune disease. So this, I would hope that at least in some part of cancer research, there's also something like that can in the future make life much easier for a lot of people suffering from cancer. So because this is more or less like this cell therapy, and I think also cell therapy is probably one good thing for the future, where you can redirect immune cells to fight cancer or something, what is already done, but a little bit more specific and more,
And now the last question. So if you could ask the immune system only one question and get a clear and honest answer, what would you ask?
Why do you fail?
I mean, that's a good one.
Okay, it's hard for the immune system really to know who's friend and who is enemy.
Mhm.
Then maybe I would also ask, how do you make that up?
Mm.
Then I can help you. But yeah, then maybe I would ask, how can I help you best to distinguish between good and bad?
Yeah. Yeah. So thank you very, very much for this conversation.
Yeah, thank you as well. It was also first time for me.
Tobias, thank you so much for joining us. And until next time, stay curious,
Stay critical.
and we'll see you next time for some tea.